positions of Goliath Radio or this station.
T-4 and counting.
Good morning and welcome to AirOccupy. I'm Liz, and together with my co-hosts Shannon and Jerry, we speak truth to power and occupy your mind for the next hour. I'm super excited about this show. We're going to cover healthcare, the Affordable Care Act, the Supreme Court decision from last Thursday, and we're going to be talking with Dr. Mark Ryan, a family physician from Richmond, Virginia, and part of Occupy Healthcare from its start. For more information about Occupy Healthcare, you can go to occupyhealthcare.net, and we'll put that link on our Facebook page. And mentioning Facebook, if you want to participate in our discussion, you can go to our Facebook page and post there. You can also tweet us at AirOccupy and call in if you have had problems with the healthcare insurance industry or getting healthcare. We'd love to hear from you. The number here at the studio is 386-523-1380. Just a reminder, we can't speak for Occupy, but we are independent, free thinkers who do occupy. So just a reminder about that. But healthcare, the Universal Declaration of Human Rights, which is a treaty that we are a party to, signed in 1948, says everyone has the right to health, including health care. So currently we have 55 million people in the United States of America who do not have health care. The Affordable Care Act, otherwise known as Obamacare, adds 32 million people, so 32 million more people get insurance. But that still leaves 23 million people in the United States without insurance. So we want to talk a little bit about the Affordable Care Act, what's good and what's bad. And
well, just from that perspective, before you even get into the Affordable Care Act, is the choice that was made when Congress undertook to legislate in this area. And that is no single payer.
That's true.
No Medicare for all, which was proposed and supported by lots of progressives. So they made a choice.
Yes.
And what they did was keep the private insurance market intact, basically, and are feeding 3/5 of those people into that system, essentially. I think the insurance companies love this. I noticed their stock went up precipitously on Thursday when the decision came out.
Yeah, after first going down, it then spiked. So yeah, the Affordable Care Act, it's I don't know, it's not a panacea. It doesn't do everything, although now as a woman, I cannot be treated differently than a man, which is wonderful. And the
meaning you can't be charged a higher premium based on your gender.
Exactly. Based on my gender, I can't be charged a higher premium, and insurance companies can't rescind coverage if I get sick. Or if I made a mistake on the application. If anybody out there has watched the movie Sicko by Michael Moore, he details people getting tossed out of insurance because they made a mistake on the application. The other big thing, no lifetime limit. So if I get really sick, they can't stop to cover.
Can't be dropped.
Can't be dropped.
You know, for me, I've been reading, it came out with the emails that about the kind of behind the scenes stuff with the healthcare industry, and I found it very alarming, mainly because I haven't been too sure what the healthcare ruling was really going to mean for me as an individual. I'm purchasing. I'm self-employed, so I've been purchasing independent insurance for me and my family now for about 8 or 9 years, and man, it is hideously expensive.
Well, you're at a huge disadvantage in the individual market. I mean, the system in the U.S. was quite by accident an employer-sponsored health care provider. And so your health care became tied to your job. If you weren't in one of those corporate structures, and those employers got certain tax benefits for providing health care benefits, but that's what largely has driven the system to where we are now. If you're employed by a larger employer, you're likely to have some level of health insurance. But if you go into the individual market, it's kind of an anti-insurance pool because you don't have any bargaining power. You're just one individual.
Right. I think, I don't think there's been a whole lot of information about what the healthcare law is going to mean for people changing their day-to-day life when it comes to coverage, cost, concerns and worries, which, anybody who is anybody who's living is concerned now about what they're paying and what it's going to mean. I don't think there's anybody who's paying attention who thinks they're going to go into the hospital and everything's just going to be hunky-dory, even with insurance.
Right. When I was reading in preparation for the show about the number of bankruptcies that are caused from medical illnesses, and it's actually quite startling, the numbers. I think it's 62% of all bankruptcies are directly related to health or medical costs, and of those, 75% of those bankruptcies, 75% of those people actually had insurance.
I think
they
you
were
should
paying.
repeat that.
Yeah. So 62% of all bankruptcies, and I think the statistics I have are from 2007. I couldn't find any newer, or 2009 actually. Couldn't find any newer ones, but 62% of people who go into bankruptcy, part of the cause of their bankruptcy is medical payments, and over 75% of those bankruptcies, the people had insurance, health insurance. They were paying into a program either through their employer or privately, and I think that's a.
I can actually speak to that because I had independent insurance. Now, it was full coverage insurance. It was through United Healthcare, which is a major company. First, I had it through Blue Cross Blue Shield, and then I had United Healthcare because Blue Cross Blue Shield was hideously expensive, even though we didn't have any pre-existing conditions. And United Healthcare kept going up and up, and I had the way I tried to combat how expensive it was as my income was going down through the recession is I increased my deductible. So I don't remember now what my deductible was, but it was like $7,000 or $10,000 or something like that, And I just found out that had I actually had anything go wrong, luckily I didn't, I would have been one of those people who was declaring bankruptcy because the coverage, though it was full coverage insurance, supposedly didn't really cover anything. There were all these loopholes. It was a $20,000 deductible for this, or, it's just crazy.
Right.
Well, among other things, the Affordable Care Act makes lifetime limits are no longer allowed. Dropping somebody when they get sick, that's no longer allowed. So there's these individual benefits that flow to all of us. No pre-existing conditions, preventative care, lots of different kinds of testing for women with no co-pays. But I think we should talk a little bit about the structure of what this does set up. And in terms of the individual market, it sets up these exchanges in every state where insurers can come in and list their offerings, and they're going to have a plain English way for you to compare benefits and what you're paying for. And you're going to be purchasing that in a larger group through the exchange, so you're going to have some bargaining power with the insurers to set rates more fairly.
I understand Rick Scott's not going to allow the exchanges here. Is that what I heard?
Yeah, we can get into that a little bit later. We were going to talk a little bit about Rick Scott's reaction to the Supreme Court opinion. One of the things that Scott has said he's not going to do is to take any action on enacting the law and putting it into effect until 2014. Because that was his most recent pronouncement. But he doesn't have a choice as to the exchanges because the federal law provides that on January 1st, 2013, the federal government will evaluate whether or not each individual state has made preparations to get their exchanges up by January 1st, 2014. To the extent that the states haven't done that or decide not to do that, the federal government will set up the exchanges.
Well, that's good news. You know, I think this is just a really pertinent discussion to have, because I'm fairly well read, and I don't know entirely what the healthcare law means to me. And hearing, you know, on the news that that Obama worked with the healthcare industry and with the pharmaceutical industry to pass this, you know, given the corporate interference in our democratic process, you know, I've had a lot of concerns about whether it's actually going to benefit me or not.
Well, I think from what I've been reading about it, it will impact most people, most people's lives. If you do not have insurance right now and you have to go to the exchange to buy insurance, if you have an income between 133% to 400% of the federal poverty level, you will receive subsidies from the federal government. And just as an example, so a person of 150% of the poverty level would be subsidized so that they would pay only 2% of their income, or $50 per month for a family of 4. And this
That's 1/10 of what I'm paying a month.
Yes. And so this means that if you are a single person, family of 1, 400% of the poverty level, federal poverty level at this point is $44,000. For a family of 4, that's $88,000. So if your family doesn't have insurance through an employer currently, and you need to buy insurance on the exchanges, if your family makes less than $88,000 per year for a family of 4, then you will get subsidies from the government. And then if your family is less than 133% of the poverty level, federal poverty level,
Which is what?
which is,
I think it's $34,000 for a family of 4.
I think it is. I think it's 34,000. Oh, no, it's actually 22,000.
22,000.
Oh, no, that's the federal poverty level
Yeah.
for family of 4. It's 22,000. 133% is 34. I think you're right, Jer. And then you can apply for Medicaid now. The part of the Affordable Care Act was a large expansion of Medicaid. And part of this, we'll get into the Supreme Court ruling, because the Supreme Court kind of decided that depending on what state you're in, if the state government could refuse the expansion of Medicaid, that expansion of Medicaid up to 133% of the federal poverty level. Jared, do you want to speak a little bit more about that?
Maybe we should talk about the case, because
Yeah.
one of the two big issues in the cases was whether or not the federal government could condition Medicaid money to require the states to do certain things at the risk of losing all of their Medicaid money. But in any event, the law passed, and almost immediately 26 states, led by Florida, former Attorney General Bill McCollum, who's running for governor here now, challenged the law, saying that the so-called individual mandate, and what that is people probably know a little bit more about the individual mandate because it got covered, is a requirement now under the new plan that if you're able to and you can afford it, you need to buy health insurance. And it was an effort to, it's a great insurance concept. You want the most people in this pool that we can get. And so that the risk is being analyzed over sick people and well people and soon to be sick people, and the costs come down.
So that
if you have the
actually-
healthy people opting out, largely younger people who decide, I don't need insurance, I'm not going to buy insurance. They're not in that pool for actuarial purposes, for setting premiums, but they arrive in the pool later when they show up at the emergency room and they don't have insurance and they get treated, and that payment becomes part of your premium and my premium. So they're basically getting paid for at some point.
So that mandate's actually for the insurance companies.
The mandate is I think it's both benefits the insurance companies and it benefits us with respect to what we ultimately are going to pay for insurance. Because the more people you have in the pool who are kicking in their fair share, then that money, the basic insurance concept, gets spread over lots of different people.
Another way to think about the mandate, rather than calling it a mandate, you can call it the shared responsibility requirement. So everyone is responsible for their own health care and healthcare decisions. And if, I've heard a lot about how much people are going to pay with the individual mandate. There's a sliding scale, and I can get more into the nitty-gritty.
That applies if just finished up with the individual mandate real quick, is if you don't buy the insurance, then in fact the bill says you're going to pay a penalty. And
so we're not going to go to jail for
no,
not buying
it's
insurance?
a civil penalty that's basically added to your taxes, and it's up to, I think, for the wealthiest among us, it's as low as $600 a year or $2,800, depending on what you make.
So what you might be paying for the health insurance if you'd purchased it is what you're going to pay in this tax penalty.
Probably less.
It'll be less.
Penalty will be a lot
penalty
less
will be
than what
less.
you would probably be paying out of pocket based on current premiums.
But then again, if you have a medical emergency, then you'll pay a lot more if you don't have insurance, and it could bankrupt even. We think that bankruptcy only affects lower class citizens. It's actually middle class citizens who get in a bind. We're going to go to break, and when we come back, we'll be talking with Dr. Mark Ryan. We'll be talking with Dr. Mark Ryan with Occupy Healthcare, and we'll go over a little bit more of the decision. We kind of rambled on about different stuff, but we will be right back.
If I could be you and you could be me for just 1 hour, if we could find a way to get inside each other's mind, if you could see you through my eyes instead of your ego, I believe you'd be surprised to see that you've been blind. Walk a mile in my shoes. Walk a mile in my shoes. And before you abuse, criticize and accuse, walk a mile in my shoes. Now the whole world you see around you is just a reflection.
Goliath is proud to support community organizations with messages like this.
Have you been to the newly renovated Habitat for Humanity Restore? Located at 695 Mason Avenue, Daytona Beach, between Nova and US 1, the store is open Tuesday through Saturday from 9 to 4:30. New, used, and surplus donated goods of home furnishings, appliances, and building materials arrive daily. Our donors and customers help Habitat serve more families through the renovation and construction of affordable housing. Stop in today or phone at 386-226-2006 to arrange for the pickup of large donated items. Again, the number is 386-226-2006. If you value the opportunity to recycle, reuse, reduce, and rebuild, you will be a big fan of the Restore. The Restore supports Halifax Habitat for Humanity. Stop in today.
Welcome back. This is AirOccupy. I'm Liz, and we're here with Jerry and Shannon. And Mark, we have Dr. Mark Ryan on the line. We're going to talk a little bit about... Dr. Ryan, are you there?
Yes, I'm here. Can you hear me?
Yes.
Great.
Hi. Thanks for joining our show.
Glad to have the opportunity. Thank y'all.
Great. We were just getting around to talking about the decision, the Supreme Court decision last week that actually approved the individual mandate, and we hadn't gotten around to talking about some of the Medicare provisions, the Medicare expansion yet. Medicaid. Thank you.
What were your impressions of the decision?
I actually posted on the website about it. I think it went out Friday morning. And the way that I'm perceiving it is this is a really important first step, but not the end of the battle by any means, both in the sense that the protections that the ACA embodies are going to be under attack in the upcoming electoral season. If they're already under attack, but they'll be vulnerable. So we need to make sure we don't lose these hard-fought steps, but at the same time acknowledging that there's an awful lot more work to be done. I heard in y'all's introductory comments the note that there's an awful lot of folks that won't benefit from the law.
Right.
Some by virtue of accidents of the way it's designed, and some very intentionally written out. But the approach that I'm taking on this right now is this is a significant step. This does embody a lot of really important protections for patients and take some important steps at looking at how to change our healthcare system down the road to make it a more effective, more efficient system. But that there's a lot of things that we now, once this is safe, eventually, hopefully, we need to start looking towards finding the gaps and fixing those too.
What's your view of retaining sort of the private health insurance company model? Is that a good thing for the future, or is that something we ought to look at?
So I think that this is one of those things that even if you look at the contributors to the Occupy Healthcare blog, we are sort of a mixed mind on this. There's a lot of folks on our side that would have looked at single-payer options as a more beneficial thing, but the politics even around this step that we have right now were so contentious that something more broad, something wider-reaching, something bigger would have been hard to envision happening. I think personally, speaking only for myself, that I think that the system we have is designed through the private plans. So rather than trying to rip it out, this at least gets protections in place and extends benefits. I was a big, strong supporter back in 2009 for a public option as part of the exchanges and as part of the market, but of course we saw the politics around that not go very far either.
Right.
So my perspective on it is I'm not real keen on supporting for-profit industries, but this was the most efficient way to get some extension of coverage and some protection of benefits. Now that this is in play, my hope is that this is something of a paradigm shift, that if the law holds true to the anticipated benefits and people start seeing significant benefits accrued to themselves, to family members, to the community, it changes the paradigm from healthcare is something that you can get if you're employed and have a beneficial employer who wants to give you a good benefit, or you're independently wealthy enough to buy your own insurance. And it changes the paradigm to one where everybody should have access to health care, be it through insurance or some other system. But that it really is a fundamental need for every person to have access to health care. And up until now, the country has kind of been divided 50-50 on whether we even believe health care is right.
Right.
Maybe this is where that paradigm shifts and we start looking at it more as everyone gets health care, and the question is how best to provide that.
Yeah, we've been seeing some of these figures where the U.S. per patient pays twice as much as, say, the European countries, and we have like the 37th best medical outcomes for that amount of money.
That would be less than Saudi Arabia, Oman, Morocco, Colombia, and Chile.
Yes.
Right. When I blogged about Occupy Healthcare, the very first post I put up, we're just behind Costa Rica, and we're behind Dominica, Chile, Greece, Cyprus, and we're just slightly above Slovenia and Cuba. And we spend twice as much per capita, as y'all noted. If you look at us, our healthcare system ranked in the developed nations, so the most affluent nations, I think there's a ranking of 13. And then looking at 7 Western-style democracies, basically anytime you compare us to our economic peers, our healthcare system ranks, if not last, then second to last in almost every measure. And we're paying an awful lot for a system that is not actually achieving high-ranking goals.
Right, and I think one thing some people don't understand, you hear, the King of Saudi Arabia came to the United States for health care, and that's true. We do give very good health care to people who can afford to pay for it. The Cadillac health cares, the gold-plated service that some people can come to the United States and get, but that's not really the service that everyday Americans get.
The
So it's
99%.
the 99%, exactly. The 99% get. So there is kind of a two-tier system.
Well, I would actually say that those examples are disingenuous in a couple of different ways. First, when some well-known leader from another nation comes here for health care, they're getting very high-intensity, very specialized health care. That isn't inherently the best health care. You know, the
Right.
countries that do well with their healthcare systems are the countries that put a lot of emphasis on primary care, coordinated care, and integrated care, and that really prioritize primary care first and then the subspecialty care afterwards. So those examples plucked out of context are just not really representative of the situation in terms of what it means to have good health care. The other example that you see a lot is, well, the United States does best compared to other countries in terms of the cancer care that we provide. And I think it comes back around to the fact that we provide very good, high-cost, high-intensity care, but that is not necessarily good health care in the global context.
Understand. How have the other providers, the other doctors, the other hospitals that you travel through and engage with, notice their reaction to the law has been fairly muted in the public discourse over this, and I'm just curious about that. It seems to be a large measure of doctors are for the law, but it's hard to tell sometimes.
I think it is hard to tell, and I don't think that any of the polling or any of the information out there really helps us. Some of the polls that show that physicians are really not in favor of the law, if you dig into it a little bit, they're not done by polling groups that would be considered terribly impartial. I think some of them have been done through CERMO, which is a fairly conservative physician community online. So I question how well you can expand any of the polling out there to incorporate physicians as a group. I think now it's a little bit deceptive also because the people I contact are in two different areas. One is the people in my department where I work, which is actually a fairly, I think, liberal, progressive sort of group, which I think sees the law similar to the way that I do in general. But Richmond as a community is a fairly conservative community.
Right.
So I think there's an awful lot of folks who, if you went out and talked to the average Richmond physician, they would be not terribly happy about them. Now, I also, aside from doing the work I do with Occupy Healthcare, I'm a member of the board of directors for the National Physicians Alliance. And NPA has been working really hard to be that progressive voice for physicians. Most recently focused on the ACA and the healthcare arguments, the Supreme Court arguments, and the decision last week. But also looking at other aspects of healthcare in terms of trying to remove industry influence from physician practice, ensuring access to healthcare for all. NPA has tried really hard to be available as a public voice. So again, I guess I'm in my own echo chamber a little bit, but I'm working with a lot of folks who believe that this was a really important step and are trying to make sure that it's known to the public that there are a lot of physicians who did like this law.
We were thinking about that a little bit in the context of what's to come with respect to the expansion of the Medicaid provisions, and we've had our own not really popular governor say that not only is he not going to take the expanded Medicare monies, he's not going to set up the exchanges, which is kind of silly. But how's Bob McDonnell, how's your governor reacted to the law?
I think it's still very much in a wait-and-see approach. In Virginia, the governor did put together panels to help figure out how to implement the healthcare law or what the implementation might mean, and has the recommendations, and apparently some background work has been done, but there's been nothing formally organized. The discussion about establishing exchanges and such didn't go very far in our last General Assembly session. I haven't seen a public statement that specifically says one way or the other that they will or will not do it. I think that the politics around it are complicated. Of course, Governor McDonnell is considered to be on the short list as a potential vice presidential nominee.
Right.
Whereas our Attorney General, Ken Cuccinelli, who was one of the first to sue to overturn the ACA, is looking to run for governor in the next election. So you have one person in the leadership who might be willing to sort of accept some of the ruling and go forward because it matches a lot of what was done in Massachusetts already, and now that the Supreme Court's decided, maybe it's more acceptable. But the Attorney General, who still believes that this law is an improper step from the federal government.
Do you think the providers might become a big
I do.
put pressure
I
on
think,
the leadership in these states to take the money?
Yeah. My understanding of the Medicaid expansion is if a state were to choose not to accept the Medicaid expansion, the states will still be carrying a certain amount of burden of cost for uninsured and uncompensated care that a lot of states end up having to make that up in their own budgets. As the ACA takes away DISH funding, the funding that helps support hospitals in rural and underserved communities, as that funding starts to vanish because the healthcare exchanges, the expansion of healthcare access, the affordability changes, and the Medicaid expansion were supposed to replace that funding. As that DISH funding starts to go away, then you'll have a lot of hospitals that work with underserved communities facing a much bigger gap in what their operating revenues are going to be. And you're going to have a lot of physicians and hospitals, and I think lobbyists on both sides, pushing states to take this expansion because it's just otherwise not supportable within the practices in the hospital system.
Yeah, we have, out of 18.5 million people, we have 4 million uninsured. And I guess it's the 5th highest rate of uninsured in the country.
It's in Florida.
In Florida.
I think it's going to come down to, I wouldn't be surprised if a number of the states and governors right now that are saying that they will not accept it under any circumstance end up getting really significant pressure from healthcare providers and hospitals and such to take the accept and expand Medicaid the way it was intended, and that they'll do so kicking and screaming and grudgingly, making a point that they fundamentally disagree with the action, but that they're being pushed to do it by outside influences. But it seems sort of difficult in my mind to think that it won't go forward, that there won't be some action in that direction by the vast majority of states.
You know, a minute ago you mentioned pressure on physicians from the industry. Could you talk a little bit more about that?
Well, so not so much pressure as influence, in the sense of looking at how one of my personal things that I'm interested in and that NPA works on is looking at the issues around how drug company marketing, drug reps, industry money influences physician practice. So as a physician who feels that these influences are not oftentimes for the better, it's one of the reasons that I'm as active with NPA as I am.
What could you give some examples about that? And you know, I don't think it occurs to people when they walk into their doctor's office that this influence is going on. You know, they're presented with this option or this medication or that medication, and I don't think they, you know, you're supposed to trust this authority figure, this physician, you know, who's got control over, you know, how well you feel, and I don't think people take that into account.
They should look at the pen that the doctor is writing with.
In my pediatrician's office, that pen said NutraSweet to stop obesity.
Nice. It's so different layered that it's hard to give one easy, simple example. The way that drug reps bring information in, the way that they present information. To get a little nerdy for just a minute, the idea of relative risk or relative improvement versus absolute. You know, if someone has a risk of a heart attack that's 1 in 1,000, and this new drug makes it 1 in 2,000, then you've only reduced the actual risk of a heart attack very little, but the absolute risk has been cut in half. So the way that industry tends to present its information to physicians, the way that industry tends to show the benefits of meds, tends to highlight what they want to highlight, as opposed to what the actual benefit might be. The fact that advertising pushes physicians and patients into some of the more expensive treatment options, where maybe the older, generic options would have worked just as well. There's been some really good work done by ProPublica, at least in partnership with NPR. I think ProPublica's Dollars for Docs series, where they went and they looked at what physicians were getting paid by pharmaceutical companies for being on speakers bureaus and consulting, and they've done some other research in that same study, in the same series, looking at how if a physician is on a speakers bureau, then it actually not only influences their audience, but it influences that physician's prescribing patterns pretty significantly.
I'll find that and put it up on our website. One of the things that I noticed that was in the Affordable Care Act was what some people were calling "quote unquote" death panels, the Patient-Centered Outcome Research Institute. And I know that they got $500 million in seed money to start a nonprofit to compare the effectiveness studies of different treatments. Right.
Yeah. So the PCORI is the abbreviation for that organization, and it's just easier to say. PCORI is designed to help identify research and outcomes that actually matter to patients, and put funding behind that where it may not come from an industry or a private source. PCORI is still in the process of establishing their initial research agendas and starting to look for the initial proposals. I think all of that is just now happening. And the intent is to take research studies that may or may not benefit individual companies, but that could benefit patients, or at least help identify the best treatments for patients, and support that research heading forward so that physicians and patients actually have a better sense of what's out there and what the benefits are. On Occupy Healthcare, we haven't really talked about PCORI so much. It can get a little bit buried in the acronyms and the wonkiness, the policy depths. But the underlying intent, I think, is very much aligned to really figure out where healthcare will benefit patients as much as possible, knowing that the research has not always looked at that. The for instance would be that does a patient necessarily care that their cholesterol went from 120 to 100? The patient individually may not care at all about a change in a number. The patient may really care that 5 years from now they're not going to have a heart attack.
Mm-hmm.
At the end of the day, that's what we call a patient-oriented outcome. That is a patient outcome that really matters. Not whether your A1C and your diabetes went from 7.5 to 7.2, but are you going to lose a foot?
Right.
So
your diabetes?
You're saying that the industry might be measuring it according to the number when the outcome may not support that, the validity of whether that number is really important.
I think so. A lot of research these days is done by what we call surrogate outcomes. So we know that lower A1Cs in diabetes, for example, better sugar control equals better outcomes in general. So that A1C, that sugar measurement, has become the standard of an awful lot of diabetes research because it's easily measured and you can see changes within 6 months or within a year. Whereas the long-term outcomes of are you going to lose a foot may take 5, 10, 15 years. So to get medicines and drugs and such on the market, you end up with a push to get things done more quickly and more efficiently, and that's where a lot of those surrogate outcomes come into play. So these reforms cannot be left just to physicians or providers. They can't be left just to industry. We need to get the patient's voice into this. And the PCORI, part of their governing board, if I'm not mistaken, includes organizations and patient representatives. It's not just a bunch of academics.
Mm-hmm.
There's actually patient-focused organizations on there who can look at these research applications and say, as a patient, this doesn't really interest me, but on the other hand, this other proposal really does speak to me.
Yeah.
Right.
One thing, you mentioned Occupy Healthcare, and tell us a little bit about that group and why you guys started and what you've been doing.
Sure. So Occupy Healthcare started late last year, sometime around late in September, early October, but it came out of a lot of ongoing conversations that were being shared back and forth. Everyone in Occupy Healthcare sort of knows each other through interactions on social media. Very few of us, when we started, had met face-to-face. But from talking to each other online, from sharing ideas and conversations, at the core of our interest was, a couple of different factors. One of them being an understanding, as y'all pointed out already very well, that the healthcare system we have doesn't live up to what it should. It's expensive. The outcomes are not up to the standards we should be demanding or expecting of it, and the fact that we are not reaching the goals that we should reach, and that a significant redesign was going to be necessary. The second piece was the fact that we really have to focus any redesign on the patient's well-being first. At the heart of it, my job as a physician is not, unfortunately, it's measured this way, but my job is not intended to just bring in patients and be productive and bill out a lot of service. My job, my profession, my obligation is to help my patient, and our system is not terribly well designed to do that. So there was the desire, the recognition of the flaw, the desire and understanding that change and redesign was necessary, that patients needed to be in the center of that design, and that there were a lot of different voices out there pushing on these ideas and pulling in different directions, and that this would be a way to try to unify those voices, to make individuals heard more clearly as part of the group. And then starting to identify for the community what resources are out there that they need to be informed about, that they need to learn about, that they can use to start to push, even if it's only at their individual physician or provider level, to start to make the system more responsive to them.
Highlighting what you just said about that obligation to help the patient, here we came up with a program that was supposed to help, given that the outcome for children who are uninsured, I want to go back to this, given that the outcome for children who are uninsured is a higher, rate of it dying than children who are insured. We came out with this sliding scale as so that people who weren't necessarily at the poverty line could have coverage too. They would pay into it. It wasn't a giveaway. It's not for people who were unemployed necessarily. It was just for people who had middle to lower income. And as a parent, as the economy tanked, I checked into that. It was called Healthy Kids. And it's through major insurance companies, Blue Cross Blue Shield, Cigna, United Healthcare. When I called every pediatrician that we'd seen, none of them would accept those insurance companies under the Healthy Kids program. Only if you actually purchased it independently, not with any, not on the sliding scale. Which was of concern to me then. I didn't go with it because, I don't want to take that kind of risk. Right. So I'm paying insurance premiums I can't afford. And I wonder what that means with the new healthcare act. Right.
Yeah. Unfortunately, although Medicaid is a really important lifeline for a lot of folks, its reimbursement is not all that great in almost any state. Some are better than others. But in Virginia, for example, the cliche is that you lose money for every Medicaid patient that you see, that just the staff costs and keeping the lights on to see a patient, the reimbursement is so low that a lot of physicians have trouble taking on new patients or a lot of patients through the program. But the ACA actually targets those Medicaid rates and pushes them up to Medicare rates, which, if you ask a lot of physicians, is still not super duper awesome, right. But is better than Medicaid. And the hope is that will start to allow the people that are already participating keep their participation, and perhaps start to move some of those folks who weren't participating in a direction that they would be more willing to.
Well, Doctor, thanks a lot for joining us today and giving us this brief exploration of law. We'd like to have you back on at some point to talk about some of these other, I know we had some questions about the preventative care model that's going to be used now, really, that we do stuff up front, team doctoring, lot of other aspects of the law that I don't think people realize are there, and where we're are going to inform where we go.
Mm-hmm. Yeah, no, I'd be happy to come back. I think that as physicians and, you know, those on Occupy Healthcare, those at MPA, but also I think as a nation, as patients, as providers, as, you know, these one-to-one care teams, there needs to be really transformative change. And there may be different agendas in place, but at the heart of it, there's an understanding that this needs to be fundamentally different. And the ACA starts to move in that direction. Some of the things like the preventive care that you mentioned, the lifetime limits, the insurance reforms, all of those are really, really important first steps.
Yeah.
But I think that there needs to be bigger change down the road than that. And I'm happy to, you know, talk to y'all later on for other times and other opportunities to touch base and do that.
That'd be very cool to
wonderful.
Continue that.
And your website, just to let everybody know, if they want more information about Occupy Healthcare, they can find it at occupyhealthcare.net.
Right. Occupy Healthcare, all run together.
Oh, all one word. Great.
All one word.
Great. Well, thank you so much.
Thanks a lot.
Awesome. Thank you. Have a nice day.
You too.
Bye.
Bye-bye.
So we're going to go to a break, and when we come back, we'll talk a little bit about a little bit more about the decision, healthcare decision from Supreme Court.
I woke up one morning, I was feeling sick, called up the doctor to see me quick. Voice on the phone said with no hesitation, if you've got insurance, you're our patient. I said, it's just a sore throat, I can pay the bill. She said, well, it'll be $95 to look at your tonsils and $150 to establish you as a patient. So I called around to some companies and I said, I'd like to buy some insurance, please. And they said, we've got to examine you first, find out if you're an acceptable risk. We got to make sure you won't actually get sick. You know, health insurance is for healthy people. So they analyzed my blood and my pee, and they scrutinized every inch of me, took the medical history of all my relations back about a dozen generations. Then they said, we gotta know one more thing. Do you have any pre-existing conditions? Just one, I said, but it's terminal.
Chair City Supply, a 55-year-old distributor to the furniture industry, now has a product line designed just for you, whether you are a home hobbyist or a professional cabinet maker. For years, we have stocked many quality brands of product for the furniture industry. Now we are able to offer you the same quality products and pack sizes that fit any custom woodworker's requirements. Chair City Supply offers a wide selection of cabinet hardware, professional custom stains, any type of screw or hinge you need, and everything to complete your project with style. Visit us at chaircitysupply.com to order today. That's chaircitysupply.com. And we're back. It's funny how the live radio shows work, because we think we're going to talk about something, the Supreme Court decision, and we ended up talking about the law, the Affordable Care Act, otherwise known as Obamacare. But I think it works to everyone's benefit in the end.
Yeah. Now we've decided that we don't need to really talk about the case. All you need to know from the case is they reviewed the law and they upheld the law, and so we're going to go forward with what the law is about, and our time is probably better spent talking about what are the attributes of this law. What does this law mean to people?
The law will have a lot of consequences for you as a citizen of the United States. You will get preventative care for free without a copay, so you can go to your doctor once a year and say, let's just check it out. What's going on? If you're a woman, you can get free mammograms, and does it include pap smears as well?
I'm sure.
I believe it does.
I think it does. And then as a man, you can get a free prostate exam, I'm sure.
If you're a parent with kids between, I think, 18 and 26, you can continue to carry those people on your your kids on your health insurance policies.
Which, with more and more young adults living at home because they can't find a job, that could be really handy.
Yeah, if you if you go on to the exchange to buy insurance companies cannot discriminate against you based on your sex or your age or your location. People in the same place, in the same general location, who are the same age, will get the same, it will cost the same amount across the board, but that excludes tobacco use. So.
Small employers, people with less than 25 employees who want to offer health insurance will be able to receive up to from a 35 to ultimately a 50% tax benefit from providing coverage for their employees.
Did I understand correctly that people making under $88,000 a year could not be charged more than 10% of their income for health insurance?
Yes. It cannot go over 10% of, well, for anyone, it cannot go over 10% of the income, even if you get insurance through your employer. There are some specific details on that.
Tax credits.
Yes, there are tax credits. I would encourage everyone who wants more information about the Healthcare Act. The Christian Science Monitor has a great series about this, about the Healthcare Act and how it will affect you personally. And we will put that up on our Facebook page, and I'll also tweet it out. And you can email us if you want more information about that.
I do have, one other thing I read, that some existing programs will be grandfathered in, and I wondered if that meant that if you already had independent insurance, that you should pay careful attention to make sure that you're still getting the best deal, or, would you just sort of continue paying for substandard, overly expensive care?
I'd wait till the exchange is open
Yep.
and then make an evaluation. Be a consumer. Go look on the exchanges on the internet and compare the policies that insurers come in and offer there to what you have. And if it's beneficial to you and you can pay a lower premium for at least as much coverage or more, then it's a no-brainer.
And competition, right? The free market. I would be remiss not to mention, and I know we're running up against the top of the hour, the national gathering. Occupy had a national gathering, or is having a national gathering right now in Philadelphia. I know some great discussions have been coming out of that. I participated in some of the discussions on Occupy Cafe. I would recommend, if you want to hear what's going on in National Gathering, or you just want to have some really great conversations, go to Occupy Cafe. Occupy Cafe is also holding, I think tonight is the last night, but they are holding a nonviolent communication seminar from 6 to 8 p.m. Eastern Time, which I'm hoping to participate in. Looks like we have a call. We'll go ahead and take AirOccupy. You're on the air. You have about 30 seconds.
Oh, hi. This is Dustin Slaughter. I was just calling from the National Gathering.
So, quick rundown of what's going on. I know you talked a little bit about the process that we went through. What's happened?
Well, it began last night, and it went fairly well. Today we're going to be doing more of that. And we just have to wait and see what happens with it. So
if people want more information about what's going on at the National Gathering, go to, give us the website.
Yeah, it's www.occupynationalgathering.com. And if you'd like to follow us on Twitter, you can follow us at OccupyNG.
Okay, great. Well, thank you so much, Dustin. Love to talk to you more in the future, and hopefully next week. This has been AirOccupy, another week, and
peace.
This program was paid for by its sponsor, which is solely responsible for its content and the views expressed. When you hear Goliath bark, you know you're tuned to WELE Ormond Beach.
Americans plan to celebrate the country's birthday more than 50 miles from home. It's partly an accident of the calendar, according to Doug Shoup.